I'm going to do a clinician's perspective of resistance in hepatitis C, and I'm very much going to look at this as a glass half full rather than a glass half empty. Let's see if I can get this to move ahead. So let's just start off by where we're at with DAAs in 2018. This is a slide from Heidi Weidemeyer presented at last year's EASL, so in 2017, looking at current and upcoming regimens for hepatitis C treatment. These two have fallen off. In other words, their clinical development has stopped. And so all the regimens that we're ever going to get for hepatitis C now exist on this slide base. So the hepatitis C pipeline has stopped. Okay, so we have in our hands about 10 to 11 regimens depending on where you are in the world. And so this is what we have to use for hepatitis C. So the landscape is changing in terms of the way we're treating our patients. So this is data from the German GECKO cohort, which is really fantastic, but it just shows you what is happening to patients over time with DAA-based treatment. As you can see, we've got less pre-treated patients. In other words, we're treating more naive patients now. We're treating less cirrhotic patients because they've all been treated, or most of them have been treated. We've got probably similar numbers of co-infected patients that we're treating, and we're also treating more people on methadone substitution programs. Outcomes over time have also changed. In other words, we're getting less patients with relapse. In other words, our therapy regimens are getting better, but we're losing more patients to follow up. And so the way we look at this whole concept is going to change over the next few years. I think what is really important, and Francesca has already mentioned this, is that with the new generation regimens, our treatment response rates are brilliant, even in real-world cohorts. And you know, we've seen this data in another form already today, but this is looking at 12 weeks of soft-fel without ribavirin in an Italian real-world cohort, and you can see you're looking at 99% SVR12 rates. In other words, very few people are failing now. This real-world cohort can also be translated to HIV co-infected patients. These are no longer difficult to treat. This is the ANRS cohort. And again, you can see way over 95% SVR12 rates, even in cirrhotic patients with HIV hepatitis C co-infection. So what are the clinical implications of failure and resistance? And I want to demonstrate this by telling you about 2 out of 160 patients in the role-free HIV Hep C co-infected cohort that have failed to date. Okay, so remember those numbers, 2 out of 160. So patient 1 is MM. He's an HIV MSM, well-controlled HIV, CD4 count of 650, undetectable viral load, gets acute genotype 1A hepatitis C in November 2017, fails to clear virus spontaneously as predicted by the 4-week rule. And if anybody doesn't know the 4-week rule, come and speak to me afterwards. We'll talk about this. But he's really keen on early hepatitis C treatment, and so he enrolls a randomized control trial of 6 versus 12 weeks of sofosbuvir velpatasvir for treating early hepatitis C. His end of treatment RNA is undetectable. He gets randomized to the 6-week arm, but by the 4-week period after stopping therapy, his virus becomes detectable. We go on and do some clonal sequencing of various regions of his hepatitis C, and it is a genotype 1A virus, and there's 90% homology to the original virus. In other words, this is a true relapse, not a reinfection. Patient 2 is another role-free patient who's also an HIV-positive MSM who's got well-controlled HIV, Hep B, and hepatitis C, and is currently on Truvada dolutegravir. He acquires genotype 1A hepatitis C in 2007. He tries PEG and RIBA for 24 weeks, relapses. In 2014, he gets diagnosed with Child-Pugh-A cirrhosis, a platelet count of 105, albumin of 35, alpha-fetoprotein of 15, and NHS England provide him treatment in 2015 on the expanded access program, and he gets 12 weeks of every 3D plus ribavirin. Unfortunately, he breaks through at week 8. So remember these 2 patients, and we'll come back to that. The questions that we need to try and answer is who's likely to fail, who is likely to fail with resistant-associated substitutions, what mutations are most likely, and what's the significance, and then finally, what options have we got available to treat these patients. So when you consider a failing regimen, there are four things that you need to think about. You need to think about the therapy that you've given this patient. You need to think about the patient and their characteristics. You need to think about resistance. And clearly, you need to think about other things, including adherence and drug interactions. So we knew right from the very beginning as we started to use DAAs, and this is data from the UK again, looking at negative predictors of response to sofosbuvir-based therapy. So this was either sofribur or peg-sofenribur. As you can see, there are a number of negative predictors that are patient-related, at least in the early DAA era. What we didn't know at the time was whether NS5A associated substitutions made an impact in this particular group of patients. HCV Target came along. This is a big national cohort in the States looking at real-life response to therapy. And as you can see at the bottom here, in a multivariate logistic regression analysis, factors that were independently associated with lack of SVR included a lot of patient-associated factors, although resistance at this stage wasn't measured in this group of patients. So do baseline RSs have an impact? And I think they do, but this is very much dependent on the barrier to resistance of your initial regimen. This is also needs to be taken in association with viral load, genotype, length of therapy, and characteristics of the patients. And this is exemplified, perhaps more than anything else, by this particular regimen, grazoprevir-elbasvir, which is a PI and a first-generation NS5A inhibitor, which had a relatively low barrier to resistance for genotype 1A patients. It's also probably exemplified in this particular regimen, ABV3D plus ribavirin, but in a more difficult to treat patient, so cirrhotic, and we've got genotype 1A. So let's look at some data. This is a C-EDGE study with one of the licensing studies using 12 weeks of grazoprevir-elbasvir in treatment-naive patients. And this is looking at the impact of baseline NS5A in terms of SVR12 in genotype 1A infected patients. And as you can see, and this is looking at population sequencing versus next-generation sequencing at a 15% and a 1% cutoff. And that it didn't really matter. And I think Francesca's point was very well made. That 15% is probably reasonable enough in the context of hepatitis C resistance, but you could see that in the genotype 1A population, there was certainly an impact of baseline NS5A resistance testing in terms of SVR12 to grazoprevir-elbasvir. When you looked at this data in a little bit more detail, what became really more important was that this impact was perhaps related to the baseline viral load. In other words, it was not just the NS5A resistance, but that in association with a high viral load that made a big difference in terms of outcome with this particular regimen for 12 weeks. Turquoise 2 was an ABV3D study in compensated cirrhotic patients. And again, they looked at 12 weeks versus 24 weeks. And as you can see, we were certainly starting to see an impact of the shorter duration here in terms of compensated cirrhotic patients. And if you then homed in a little bit more in terms of what is it about these compensated cirrhotic patients that makes them difficult, that it was markers of portal hypertension that became important. So low platelet counts, low albumin, and the raised alpha-fetoprotein. And based on all of this, there are different treatment recommendations for these relatively low genetic barrier regimens. And so certainly for grazoprevir-elbasvir for genotype 1A patients, the SPC suggests that if your viral load is greater than 800,000, you probably need to think about baseline RAS testing and extend duration to 16 weeks with the addition of ribavirin if baseline RASs are present. If you can't get a baseline RAS testing done, then you probably need to extend therapy and add ribavirin for this particular regimen. For ABV3D, you don't need to do that, but you need to extend therapy for anybody with significant portal hypertension for compensated cirrhotics. So what about the new regimens? So again, we've looked at this data already today. This is sofosbuvir-velpatasvir. This is the Astral program, Astral 1 to 3, with genotype 1 to 6 patients. either treatment naive or treatment experienced. And as you can see, really very little impact of baseline NS5A resistance. Astral 4 was decompensated cirrhotics with sofosbuvir, velpatasvir, again genotypes 1 to 4, and again little impact of well-specific resistant-associated variants in terms of overall response to sofosbuvir, velpatasvir. Remember, this is genotypes 1 to 4 and 1 to 6, and genotype 3, there's a bit of an issue with, as Francesca had mentioned already. So what is the prevalence of RAS in DAA-naive patients? We've again seen this sort of data, and it depends on what population you look at and what genotype you look at. And so if you look at, say, in this European RAV database, genotype 1A patients in NS5, these are the sorts of mutations you'd see in genotype 1A, but if you look at genotype 1B patients, there's a different group of mutations in 1B patients. So there is a difference in terms of populations that you look at and the genotype of the patient that you're looking at in terms of impact of baseline resistance. We've also seen this. This is the resistance characteristics of antiviral classes, and as you can see, barrier to resistance increases as we move down the generation of new drugs. So once we're down to voxiplaravir and glecaprevir, or velpatasvir and pribrentasvir, we've now got drugs with high barrier to resistance, both in the NS3 and the NS5A inhibitor classes. So, basic concepts, just to summarize for you. HIV resistance-associated mutations are enriched in patients experiencing DAA treatment failure. There's no doubt about that. And they have an impact on treatment response in specific situations. But HIV resistance is not absolute, and some patient characteristics are just as important. In other words, difficult to treat patients is where problems might arise. So future regimens, and currently, SOF-VEL or the GP combination, probably obviate the need for most resistance testing at baseline. Okay, so we've seen this too. Which of the resistance mutations is important? And the take-home message here is it's your NS5A that is going to last forever. I have to say we were all taken by surprise by this. When we first started talking about HIV resistance as clinicians, I said it's not going to be important, don't worry about it. This is a virus that doesn't integrate into the genome. It will disappear once you've taken the drug pressure off, and we'll be able to retreat at a later date. How wrong were we? And that NS5A RASes persist over time, and we can have a discussion on why they persist over time, but clearly they acquire fitness, and so there are viruses that are fit and will persist over time. Now, not only do they persist over time, but we've seen this data, they cause cross-resistance across the class, with different ones having different impact in terms of response to NS5A inhibitors. Perhaps important here is the bottom two, velpatasvir and pribrentasvir. As you can see, for a lot of the NS5A mutations that you are getting with these agents, there is a response to the next generation NS5A therapy. Now, the other thing about NS5A resistance selection is also dependent on the length of therapy that you gave the patient. So what was really important here is we learned very early from the sofosbuvir-ledipasvir days that if you gave suboptimal length of therapy, in other words, 6 weeks of therapy, in fact, very few patients emerged with NS5A resistant mutations. In other words, you were actually failing the patient because you didn't get the viral load down enough for them to kind of successfully clear virus. And so if you look at this, in terms of regimen and duration, PI-based regimens, elbasvir, grazoprevir, almost 100% fail with resistance mutations. If you look at nucleotide-based therapy, very much depends on length and the regimen that you use. So, basic concept number 2, from a clinician's perspective, the important take-home message is NS5A substitutions persist, and there is cross-resistance amongst first and second generation NS5A inhibitors. Shorter duration of therapy is less likely to result in selection of RASes, especially in the presence of a high barrier to resistance bit of the regimen, including sofosbuvir. So You've learned all of these basic concepts. Now let's go back to our two patients. So were these patients destined to fail? In other words, could I have predicted right at the beginning that these were the two patients that were likely to fail? And if they are likely to fail, are they likely to have had either baseline resistance-associated substitutions or have acquired resistance-associated substitutions? So let's have a look. So patient MM, this is our recent patient. He's got genotype 1A, he's got early hepatitis C, he's got a high viral load, and he gets short duration therapy with sofosbuvir and velpatasvir for 6 weeks on a clinical trial. Patient MN has got compensated cirrhosis, moderate viral load, not got all the bad prognostic factors for FV3D plus ribavirin, but gets 12 weeks of FV3D plus ribavirin. So let me tell you what the problem is. For patient MM, we really don't know the efficacy of short-duration therapy of sofosbuvir and velpatasvir in early hepatitis C, and this trial is still ongoing, so I can't disclose results yet, but this will report in the next 6 months or so, and I'd be very interested to see if short duration with soft-vel for 6 weeks actually works for acute or early hepatitis C. MN was a little bit of a surprise for us because this guy had no bad prognostic features in terms of getting 12 weeks of FV3D plus ribavirin. However, as we went back and spoke to him, and he had a breakthrough, adherence was his problem. In other words, the tablet burden for this regimen was too large for him to kind of take 100% of the therapy 100% of the time. So what do you think about resistance testing? We've already seen that short duration with soft ledipasvir didn't result in mutations, and not surprisingly, patient MM had no baseline or treatment emergent resistant-associated substitutions. His therapy was just not long enough to clear him of hepatitis C. MN also had no baseline resistant-associated substitutions. Adherence was his problem, and not surprisingly, he had a number of treatment-emergent mutations, both 155K, 168E, 28V, and 30R. Please don't remember these numbers. I can't. Francesca is probably the only person in the world that can remember these numbers. But just to think about NS5A mutations as a class. So, in the last 10 minutes or so, how do we retreat our two patients? What can we do in terms of managing the people that we have in clinic in front of us? So let's show you some data. So this was in the old days of sofosbuvir, ledipasvir, where they had numerous different regimens of sofosbuvir, ledipasvir, and people have been treated either with short duration, 6 weeks or 8 weeks, and had failed. And so this was a number of rescue therapies where they gave either sofosbuvir, ledipasvir for 12 weeks or added ribavirin. As you can see, addition of ribavirin in retreating with the same regimen actually works if you treat for longer with the addition of ribavirin. In cirrhotic patients, however, this didn't do so well. They didn't have a 24-week arm with ribavirin that would have been very, very useful to make a comparator with, but this was then replaced by sofosbuvir velpatasvir. So how about retreating with sofosbuvir velpatasvir in those patients that had not responded to either very short durations of sofosbuvir velpatasvir or ineffectual doses of velpatasvir in the very early days? And again, you can see if you prolonged duration out to 24 weeks and added ribavirin, you were getting SUR12 rates that were almost approaching 100%, except this particular group of patients, which is the genotype 3 patients, which are difficult to treat. Okay, so what about the new generation of drugs? This is glecaprevir, pribrentasvir. This is the Magellan-1 study. This is patients who had previously failed a DAA, and they were retreated with either 12 weeks of GP or 16 weeks of GP. And just to cut a long story short, if you had either an NS5A mutation or a combination of NS5A and a PI mutation, you were unlikely to succeed with retreatment with GP either for 12 weeks or 16 weeks. And it didn't matter whether you had mutations or not, just exposure to these drugs was enough to stop you succeeding with 12 or 16 weeks. So we've seen the Polaris 1 study already. This is NS5A experienced patients treated with triple therapy now with sofosbuvir, velpatasvir, voxilaprevir for 12 weeks. And you can see these patients had a numerous different exposure to NS5As, ledipasvir, daclofenacin, ombitasvir, others. And as you can see, across the board, very good responses with 12 weeks of the triple therapy from Gilead. We've also seen this data, so this is now the next extension of the Magellan study. This is now GP, but adding sofosbuvir and adding ribavirin for 12 to 16 weeks retreatment after failure of GP for 8 or 12 weeks. And as you can see, across the board, we're now looking better if you add ribavirin, if you add sofosbuvir to this particular regimen. So, treatment decisions regarding HCV retreatment post-failure need to be ideally guided by RAS testing. The triple therapy from Gilead, OGP plus SOF plus RIBA for 12 weeks are ideal retreatment options, including those with compensated cirrhosis. Now, this is the important bit. Both voxilaprevir and GP contain a protease inhibitor, and so you cannot use these for decompensated cirrhotics. And decompensated cirrhotics become difficult. And for these patients at the moment, the only option we have is retreatment with SOF-VEL plus RIBA for 24 weeks. So this is a group of patients that you really do need to be careful about. So what did we do with our 2 patients for the last couple of minutes? Actually, we said wait for the triple, but he was very keen on retreatment and has just gone to a buyer's club and got himself SOF-VEL for 12 weeks. I'm pretty sure this will succeed. I have no doubt about that. MN, we have a compassionate use program in the NHS. God, NHS is so slow, but we won't talk about that today. But he has got triple therapy for 12 weeks. He remains compensated, and so we can use PI-based triple therapy for his retreatment, remembering that he has mutations across the board. And so I'm going to end there by saying we'll go back to the EASL recommendations. Testing for HCV resistance prior to treatment is not recommended, except in special circumstances where you're going to be using grazoprevir, elbasvir, where you probably do need to think about baseline resistance testing, or if you're going to be using sofosbuvir, ledipasvir for genotype 1A patients, where you do need to think about baseline resistance testing. But resistance testing prior to retreatment in patients who failed DAA-containing regimens is extremely useful, and it's something that we should all be using and doing for retreating our patients. So I'm going to stop there and say that they lived happily ever after. Thank you very much.